This is a video about bowel endometriosis. My name is Suzanne Johnson and I'm a gynaecologist from Southampton. When we're thinking of bowel endometriosis, we think about whether it's deep or superficial, whether or not it involves the vagina, how low the lesion is, and whether or not it's stenosing. Bowel endometriosis, deep endometriosis, is very common, and it's thought that about half of patients with endometriosis may have bowel involvement. Colonoscopy is often normal, and an MRI can't show pelvic mobility or point-specific tenderness. But ultrasound is excellent for looking below the pouch of Douglas, using a standard transvaginal ultrasound technique, and personally I don't use bowel preparation. The terminology is very confusing. People talk about rectovaginal septum, fornix, rectovaginal, retrocervical, lower, middle and upper rectum, and sigmoid. But the International Deep Endometriosis Analysis Group published this paper in 2016 and gave us a system to use for terminology. This is how I use the system, and I'll show you some ultrasound images of anatomy of the posterior vaginal fornix, the pouch of Douglas, the rectovaginal septum, torus and bowel. This is a transvaginal longitudinal view of the cervix. I've got the probe in the anterior vaginal fornix. This is the cervix, this is the external os, the internal os, the cervical canal. This is the posterior vaginal fornix. This is the posterior vaginal wall that hugs the outline of the posterior lip of the vagina. This is the pouch of Douglas, and the area below this region is called the rectovaginal septum. So rectovaginal septum is here and the posterior vaginal fornix there. And this is what it looks like on ultrasound. That's the posterior vaginal fornix. That's where the torus will be. We'll do that one next. So you can see there's quite a distance between torus and the extent of the posterior vaginal fornix. So it's a longitudinal view of the cervix again. You can see there's just a little bit of air in the posterior vaginal fornix, which is why you can see it so clearly. So in the longitudinal plane, going from one side to another, just showing the cervical canal and the posterior vaginal fornix. Now how to visualize the torus. This is a longitudinal view both of cervix and then uterus. So this is the anterior uterine wall fundus posterior, and this is where you can see where the bladder attaches to the uterus. In a straight line below that is the internal cervical os, and below that is the torus, and this area is crucial to be able to visualize when you're thinking about endometriosis. What we were looking at before, the posterior vaginal fornix, is just there. So what you do is you get a longitudinal view of the internal os and then look at that area and rotate your probe 90 degrees. So this is just looking laterally. Now I'm rotating. This is now the transverse view of the cervix at the level of the internal os. And if you go side to side, you'll be able to see the uterosacral ligaments. So if we do that again, that's the internal os. We're going to rotate on that point, internal os, torus, and then looking to side, uterosacral ligaments on one side and on the other side as well. So that's how to visualize the torus. The torus is a little way above the posterior vaginal fornix, where that posterior vagina inserts on the back of the cervix, and the torus is just a little bit higher than that. At laparoscopy, this is what that looks like, and at laparoscopy we're looking at the back of the uterus because we are looking into the patient this way. So this is her right. So you can see here, this is the torus where the right and the left uterosacral ligaments insert on the back of the cervix. This is the pouch of Douglas below it. To be able to visualize bowel nodules, it's important to put your probe in the posterior fornix. If you put your probe in the anterior fornix, you'll be able to see cervix and you'll be able to see the sliding sign behind the cervix. But whether or not the uterus is anti or retroverted, if you put your probe in the posterior fornix, you won't see the cervix because you've pushed that out of the way, but you'll be able to see bowel nodules and adhesions. So always look through the posterior fornix. But when you start to scan, the probe will be in the anterior fornix, so you can see the cervix nicely. So how to do the movement. What I do is I continually ask the patients very gently to let their legs go floppy, and I am only ever very gentle. And then I'm going to pull the probe out a little bit, and I'm going to reinsert it very gently into the posterior fornix. And this is how I do that. So there's a bit of sliding sign. Now I'm going to take the probe out a little bit, push it backwards slightly, and you can see exactly where you are. You just need to encourage the patient to let her knees go floppy. And you can see now I've got the uterosacral ligament stretched over the probe, and I can see a little bit of free fluid in the pouch of Douglas, and that's the peritoneal reflection of the pouch of Douglas just next to the posterior vaginal fornix. So again, a little bit of a sliding sign. I'm going to withdraw the probe slightly. I'm going to now insert it into the posterior vaginal fornix, and that will allow me to look at vagina, at the uterosacral ligaments, at the pouch of Douglas, and at the bowel in a lot of detail. And when you have your probe in the posterior vaginal fornix, so you've got vagina, you've got uterosacral ligaments and serosa, and then here you've got some fluid in the pouch of Douglas showing you beautiful bowel layers. And what they are, this is the serosa, which is just white. Then below that comes the muscularis, and it's really 3 layers. It's dark white, dark. These are the outer longitudinal muscle fibers, a little bit of fibrous connective tissue, and then the inner circular muscle fibers. Below that, you've got the white is submucosa and mucosa on one side and submucosa and mucosa on the other. There's the other muscularis, this is the posterior wall, and there's serosa again. And so you can see there is the potential lumen. This is what normal bowel looks like, so normal muscularis layer. But deep endometriosis in the bowel wall looks like this. It's a very thick, abnormal muscularis layer with normal coming in and going out of it. This is deep endometriosis in the anterior wall of the bowel. So where do we look for a deep endometriosis in the posterior compartment? So this is just a very badly drawn cartoon. I'm sorry about that. This is bladder, uterus, vagina and bowel. So if I start by drawing a line at the level of the torus, that's the internal os, and there is the torus, and I'm going to just continue that line along. I'm going to draw another line at the bottom lip of the cervix, and the line below that between vagina and bowel, that's the rectovaginal septum. This area here that we've just looked at before, this is the posterior vaginal fornix. This area, the bowel that is below the line of the torus, is the lower rectum. The bowel that's above the level of the torus is the upper rectum. And if you draw a line at the uterine fundus, above that is called sigmoid. So, deep endometriosis, you commonly get it in the posterior vaginal fornix. You get it in the torus and the uterosacral ligaments. You can get it in the lower rectum, and you can get it in the upper rectum. And when you're thinking about if this is all glued together, I always think bowel, ligaments, vagina to be able to make some sense of what I'm looking at. Because quite often this is what happens. It all becomes confluent and part of one huge nodule. And this is the view you get at laparoscopy. So all you see is an obliterated pouch of Douglas and a frozen pelvis. And this is what that looks like at laparoscopy. This again is the back of the uterus. This is the patient's left. This is her right. And you can see that you can see absolutely nothing. Everything is glued together. And you have no idea what the bowel is doing underneath that. But fortunately, ultrasound can tell you what's below those adhesions. So how to describe what you can see on ultrasound? Thinking about bowel endometriosis. Is it deep or superficial? Does it involve the vagina? How low is it? And does it stenose? Superficial bowel involvement is where you've got endometriosis in the ligaments here that just kind of extends onto the bowel wall a bit, but you can still see that fine white line between the outer longitudinal and the inner circular muscle fibers of the muscularis. And while you've got that maintained, this would be regarded as superficial endometriosis, not deep. So for deep bowel endometriosis, you need the muscularis layer to be involved like that. So does it involve the vagina? It's very important to try and peel these things apart. Bowel, ligaments, vagina. And you need to look for vaginal involvement, because if you're operating on these patients, the risk of a post-operative fistula is increased when you've got both bowel and vagina involved with deep endometriosis. So this is an example of a nodule of deep endometriosis involving the posterior vaginal fornix. You can see this is a nodule of deep endo. There it is in the ligaments and in the bowel wall. So we'll just let that play again. You can see that there's a nodule of deep endometriosis in the posterior vaginal wall. It's entirely separate from cervix. This is the cervix. We're just going to insert the probe again. There goes cervix. This is that nodule of vaginal endometriosis, ligamentous deep endometriosis, and bowel endometriosis. So that's an involved posterior vaginal fornix, and that's very important information. So now, how low are these bowel lesions? How to describe the level? This is really controversial. So some colleagues measure the distance from the nodule of deep endo to the anal verge. I find this really difficult to measure, especially when the pelvis is frozen. What I do is I measure the distance of the nodule from the torus. This is much simpler as it relates to a fixed anatomical point, the torus. It's a very common location of bowel endometriosis, and for measuring colleagues, this is at around 8 centimeters from the anal verge. But if the nodule is mainly above the torus, we call that upper rectum in the IDEA classification, and that would make it intraperitoneal. But the lesions below the torus, also called lower rectum, are retroperitoneal, and it's important to be able to advise your surgical colleagues to say whether or not a bowel surgeon might be required at time of surgery. So looking at the different levels, here we're going into the posterior fornix, so the torus is up there somewhere. Here you can see a bowel nodule of deep endometriosis. You can see the posterior vaginal fornix is not affected. It's all glued together, but there's no endometriosis in the posterior vaginal wall. And we're at a very low level where, the cervix is up there, the torus is up there somewhere. So this is lower rectum. In this example, this bowel endometriosis extends from both the lower and the upper rectum. You can see here a longitudinal view of the anteverted uterus. The probe is in the anterior fornix. This is the uterine fundus, this is the posterior wall, and this is the cervix. And here you can see a large dark plaque of bowel deep endometriosis that is below the level of the torus and above it. So this is a large plaque extending into lower and upper rectum. And here's the probe in the anterior fornix, and there you can see the nodule appears all the way up. So lower and upper rectum. With these views, I tend to be in the longitudinal plane, and I'm moving my probe slightly from one cornual area to the other, if you like. And then in this example, again, this is a longitudinal view of a uterus. The cervix is up there, so this is anterior wall fundus and posterior wall, cervix is there. And here you can see this extensive plaque of bowel endometriosis extending from the upper rectum to beyond the uterine fundus, so it's also sigmoid. And this is what that looks like on video. It's the anteverted uterus. You can see this big plaque of endometriosis extending all the way up and over, and there's also a big ovarian endometrioma. You can see how big this plaque of endometriosis is. Upper rectum and sigmoid. It's often multifocal as well, so in this particular case, this patient has a lesion in the lower rectum and the sigmoid colon, and about a third of patients with rectosigmoid deep endo have other bowel lesions. You need to look for them. So in this example, posterior fornix, we can see that we're well below the level of the torus. This is a low rectal lesion of deep bowel endometriosis. And in this same patient, looking near the left ovary, well above the uterine fundus, you can see two separate nodules of endometriosis there. And this was above the uterine fundus, so this is at the level of the sigmoid colon. So lastly, is the bowel lesion stenosing or not? What you do is you measure the nodule first. You measure it in 3 dimensions, and if the lesion is not linear, then you need to follow the curve, otherwise it will be the wrong measurement. And then you also measure the percentage of affected circumference. What I do is I compare the width of the lesion to the width of the bowel, and measure the angle of deviated bowel. You can also comment on submucosal involvement, though this is not so reproducible. So whether or not the bowel nodule is stenosing, we've got some surrogate markers for this. Whether the depth of the nodule is more than 10 millimeters, if the width of the nodule is more than 50% of the bowel circumference, and if the angle of the bowel is less than 90 degrees. And this comes from an excellent chapter in this book on endometriosis. And just to show the difference, we're in the upper rectum because this is a retroverted uterus. This lesion is below the uterine fundus, but it's well above the torus, which is about there. So it's an upper rectal lesion. You can see it here. And if we are measuring it, that's the length of it. The depth would be about there. This is the width of the bowel, and this is the width of the lesion. But you can see that this is essentially flat. Whereas in this bowel nodule, again, we're low rectum because this is where the posterior fornix attaches to the cervix. Got cervix up there somewhere, so torus will be way up out of the way. And this is how you would measure this nodule, because it is quite clearly a very curved lesion. All this dark is involved muscularis, and the white layer overlying it is the submucosa and mucosa. And here you can see this spikiness where the muscularis extends into the submucosa. This is called submucosal involvement. But just thinking about the angle that this bowel has been retracted into, this is 90 degrees, and that's the depth. So when you're measuring the depth, you don't measure the adjoining ligamentous deep endo as well. You purely measure muscularis. And then when you're looking at the width of the bowel in transverse now, and the width of the lesion to see whether or not it's 50% of the circumference. So this is what at surgery would look like a retracted mushroom nodule with an angle of less than 90 degrees. And we're going to suspect bowel stenosis if we see this, or if we have more than 50% of the circumference affected, or if the AP diameter, this one, is more than 1 centimeter. Those are surrogate markers for bowel stenosis. So now we've looked to see whether the bowel endo is deep, whether it involves the vagina, how low it is, and whether it's stenosing. And I would really strongly recommend these resources. Most of them are online videos, and then this excellent book on how to perform ultrasonography in endometriosis. Thank you.